Okay, so the one-sentence summary is that I'm a clinician and a nerd.
Yeah.
In a little bit more detail, I've been a doctor at the coalface for 25 years, working mostly as an intensive care specialist, but I'm also trained and ticketed as an anaesthetist or anesthesiologist for the American viewers. And most of that work was in the public sector in New South Wales, so working in the hospital system. But before I did that, I've been a nerd for longer than that, 40 years.
Yeah.
I was writing, selling and supporting software, including a practice management solution that I sold ending in about 2000, so 24 years ago. I've been involved in IT rollouts in healthcare at various levels, from intensive care to whole of system rollouts. And more recently, I guess, having the dual knowledge base as a clinician and an IT specialist has meant that I've taken up roles like Chief Clinical Information Officer, which is what I am now in Northern Territory, which is sort of blending acting more as a translator, helping clinicians understand the way IT people speak and executives, helping the executives understand clinicians and IT people, and helping the IT people understand clinicians and executives.
The nerd and the clinician intersect.
Yeah. Although the third language, I didn't really talk much about it because that's a fairly recent experience for me. So I first started having an executive role in 2014 when I was the CCO for New South Wales, which is almost exactly 10 years ago. So that's a relatively recent learning curve for me, and it's probably been the hardest learning curve for me. But that third language is increasingly critical, because in the end the executives decide where they're going to invest, where the money gets spent, what are the priorities for the business. And so if you can't speak to them in a language they understand, you don't get far.
Yep. Okay. So then this last couple of days, you have been on quite a few panels here in Australia.
One still to go. Yeah.
One still to go. What has been the highlight for you so far?
Today we talked about healthcare anywhere, anytime, and really interestingly it talked about clinicians as well as patients. And that one actually, it's not just because it's the one that's freshest in my mind, it was actually probably the most interesting one for me. But at the beginning of the conference we were talking about design centricity and using human-centered design to create better solutions for people. And we also had a session on AI. But I actually think they all centre around the same principles, which I think, so probably a bit of positive reinforcement, having what they call positive affirmation bias. But I really feel that if we constantly think about who is going to use our solutions, how and who's going to be impacted by the use of our systems, how do we design the solutions to best meet their needs, really understanding what problems they have, then we'll build great solutions. It doesn't matter whether it's an AI solution or a standard technology, whether it's a piece of software or a widget, a physical device. I think those things are critical. But I guess the sessions also reminded me that we're very different. A lot of people say, why can't health do, what Instagram did or Facebook or Twitter or whatever? Why can't we do that all-encompassing? And I think to myself, it's very, if you were a startup and you gained 10% of the world's market, or how many users are there every day on Facebook? It's a huge number, but it's still only small compared to the world's population. Problem with healthcare, everybody needs healthcare, not 10% of the population. I can turn off my Facebook account and Insta account, many people do, and life goes on, but you can't turn off healthcare. So we have a much harder challenge, because we've got to create solutions for everybody, not just a small minority or even a majority. We have to make it work for everybody. And I think a lot of our failures are around, this works for 90% of the population. Well, in Australia, that means 2.5 million people wouldn't get what they need, because 10% of 25 million, So I think that's what's come home to me today, that I think a lot of our failures is because we don't really think about all the people we have to support. We don't think of the edge cases, the vulnerable people. And so when we're designing our solutions, we often, make it work for a lot of people, but not the people that need it most. And that's been woven in every discussion that came up in various ways. So I think that's probably the common theme that I think I've enjoyed raising awareness of, I guess, and not just me, other speakers. It's been a common theme that's sort of evolved through the panels.
Yeah, sure. So then, as that theme's evolved, what have been some of the discussions around that? How do we go forward and create that whole?
Yeah. Well, one thing I feel is great is that if I think about, and I'm trying not to reflect just my own opinion, so if I think about the discussion on the panels, there was certainly a much greater acceptance that human-centered design, human centricity is going to create better outcomes than not, and that's really good, because 10 years ago I wouldn't have said that would have been on the forefront. I think understanding the needs of the edge cases, the vulnerable communities, the cultural and linguistically diverse communities, the special needs of people that are not always front of mind. I think everybody mentioned the needs to address that, whether we're talking about bias and AI solutions or building tools that can't be accessed by people of a different language group or disability. So I think that was another one that was really, really strong. And I used the term stopping being so egocentric and I think that's also reflective, because we for a long time have talked about healthcare as if it only ever happens in hospitals and general practice and specialist rooms. And I think over the last 10 years, and this has been really strong in this conference, we've seen the drift away from that to realise that there are other clinicians involved in healthcare, allied health professionals and others, but there's also non-registered practitioners, everybody from alternative medicine practitioners, massage therapists, unpaid carers. They're all critical to your health, because 98% of your time you're in their hands or your own hands, not classic Western contemporaneous medicine's hands. And I think I've seen the gradual, I don't want to use the word attack because I think it's a good thing, the gradual dissolvement of the egocentricity of discussions. And we're talking much more about patients in their environment where they need care. And not just patients, the carers too. Like I used an example today of doctors who are providing support to Northern Territory whilst they're sitting in France and Germany, because it's daylight over there, so they can provide our nighttime service. So it's not just about the people receiving the care, it's about the providers too. So I think those three things: